Disease Symposium for patients, caregivers, and families. We are so blessed in the state of Nebraska to have such amazing providers that are going to be your presenters today. They are renowned in the world of Parkinson's disease, and you could not be any better place in Nebraska than at the Embassy Suites Parkinson's Disease Symposium. Thank you. A few notes. During our lunch breaks, our morning break, our afternoon break, and also our lunch break, we have 25 vendors and sponsors who have made this day possible. Please visit their booths and their tables. They have so much good information, and you truly will be intellectually stimulated. The conference center, if you want to get onto the Wi-Fi here, is under the conference center, and then it's LVCC, so for La Vista Conference Center, 19, and then the password is 1234. Please, throughout the conference, feel free to stand up, to stretch, to do whatever you need to do. If you have any telephone calls, however, we ask you that you put your pagers and your cell phones on the silence or vibrate mode. And I know that some of you do have to take calls, but just please stand out into the atrium to take your telephone calls. We will have a guided exercise program at 12:50, so I hope you will all be in here for that. Also, lunch will be served to each table in the room, so you won't have to get up and get your lunch anywhere. They will actually bring it to your table, so no need to worry about getting in line first. We will have a question and answer session once this morning and once this afternoon. There's cards on your tables, and you're more than welcome to write a question on the cards, and we will come around and pick them up, and then I will ask the questions to the speakers, and then they will answer them. So we'll try to get through as many as we can, and what we don't get through, I will put them in the Parkinson's Post, the next edition, our newsletter, which I'm sure you're all signed up for, and if you're not, you can go to our Nebraska Medicine vendor sponsorship table, and they will get you signed up. The slides containing the PowerPoint, I know everyone doesn't have a program, but the slides are available online, and in the program is the link to go to that, and also the link will be in the slides, so you can get that link, and anybody can print those out. We also have a Nebraska Medicine UNMC photo background in the very back, and it's to my left. And you are more than welcome to take pictures of your families, of your Parkinson's disease support group, your caregivers, or whoever that you might want your picture taken of. So, and make sure that you send those pictures to me as well. The bathrooms are when you exit this room, and they are to the left. And again, feel free to go to the bathroom at any time that you need to. If you are posting pictures or anything else on social media, feel free to use our hashtag PDConference2019 to post any pictures, any comments, whatever you would like. If you don't know what a hashtag is, it's what we used to call the pound sign. Last but not least, again, please be considerate of our speakers and of all of the people around you when it comes to your cell phones. I always say that at the beginning and at the last because it never fails that somebody has their cell phone on. I would like to take this opportunity to introduce you to our first speaker, Dr. John Bertoni. Dr. Bertoni truly is an expert in Parkinson's disease, both research, clinical, and education. He has been caring for patients for Parkinson's disease for 50 years this year. 50 years he has dedicated to us. In the Parkinson's world, he is an advocate, an innovator, and a leader. Dr. Bertoni is a Nebraska Medicine UNMC Department of Neurosciences professor and co-director of our comprehensive Parkinson's disease clinic. Please welcome my friend and colleague, Dr. John Bertoni.
Wow, thank you for that great introduction. And it's so wonderful to see everyone here. This really exceeds our expectations. This doesn't happen anywhere else. There's no other university that will do this Our job is to take care of patients. That's number one. And if we don't start by educating our patients and turning on the microphone, we're not going to get the word out. And we need to make sure that everyone here has the latest information. Most of the time, places will do courses for doctors and for other people for credits, but we start where we should with the patients, the families, the ones that have to deal with this illness. The rest of us are spectators. You people are the ones that live it. So I want to go through this. This doesn't happen because of one person. This happens because of a team. And you know, we're University of Nebraska Medical Center. There are wonderful other hospitals in town, wonderful hospitals throughout the state. The enemy is Parkinson's disease. We're all on the same side. We're fighting Parkinson's. So if I can have the next slide, do I have the control here in my pocket? No, I don't. So, let's see. I do not. Yes. Oh, this is, thank you. This is, okay. I need to get the next slide. Thank you. All right. Unfortunately, I do not own these companies, but I have spoken for them and I have done work with them. So where are we now and how do we get even better? We're going to be talking about the latest in quality measure goals and what we're doing now and what we need to do in the future. So this takes teamwork, and I just want to show you Diego Torres is our leader, and we are now having the pleasure of working with Dr. Abash, who is the new chairwoman of our Department of Neurosurgery. Dr. Follett has been one that has carried the ball so far, and he has done, I know, deep brain stimulation surgery for many people in this room. This is me, and I'm co-director, and I'm honored to be here today. I want to do 51 and 52 and even more years of taking care of patients with Parkinson's. Amy Hellman is our director of our Huntington Center of Excellence. Dr. Bhatti is the other co-director of our comprehensive clinic, and we'll be talking about what we're doing there. Dr. Mara Sire is a recent addition. She is just wonderful, trained at University of Oregon with Ron Pfeiffer. Many of you know Ron. And I'm going to be told how many minutes I have left. Okay, good. Dr. Merman is the former chairman of our department, and he is a director of behavioral and geriatric neurology. Thomas Magnuson is our psychiatry, and then Julie, of course, we couldn't do anything without Julie. She's a dynamo and has connected us all together in this cause. Dr. Ariane, not doctor, this is, we owe a lot to her. She directs our fellowship and clerkships. And Nabil Syed, Sarah Doss, Deepmala Nandawar, and Aaron Smith are really, really first-rate fellows. We have case managers that we didn't get their pictures. They didn't want their pictures, but Bobby Roeder, Cindy Penke, and Laura Kruger, you know, and work with on a day-to-day basis. And all the other team members, there's not time enough to give all their names. This goes back actually before James Parkinson's, but he gets the credit because he did a wonderful job in describing this condition, didn't have the right idea of why it happens, and we're still struggling with this. This is small print. I'm just telling you, these are for the doctors. We have to use plain language and directly communicate. We need to encourage you to ask questions. We need to remember education of the patient is really number one. You're the athlete. We're just the coaches. You have to live this life. We want you to do the best you possibly can. And we give information on all these things. These are things that we look at and I try to strive for every day. I won't read them all for the sake of time. But we never, never, never give up. One of the best speeches ever was Churchill's talk at some, I think, boarding school in England. He stood up, said that, and sat down. And that's all we need to say. We're not going to give up on this fight against Parkinson's disease. So how do we diagnose Parkinson's disease? Why is it so hard? It's because each one of you are different. Each of you have a different form of it, and it's a disease with many faces. And it's not easy to see, but it takes a while and expertise to get to the bottom of the problem. What causes it? There's a complex interaction between the genes that we were born with and what we experience in our environment. We'll talk about that. But what we really want to get into is how do we live with Parkinson's disease? We can have Parkinson's disease, but Parkinson's disease cannot have us. I see people practically every week that have had Parkinson's disease for over 20 years. Some of the people next to you that you may talk to today may have had Parkinson's for 30 years. And if you control the medications correctly, if you're fortunate, you may not have such a severe form of the disease as the person next to you. You may actually have a very good life. If we can only postpone the disease and make it slow down 10 or 15 or 20 years, many people will never develop it. That's what we're working on now. This is my way of saying you're not alone. This isn't for FORE, this is 4% lifetime risk. Everybody in this country has a 4%, 3 to 4% chance. Women, it's a little less, 2 to 3%, but that's a lot of people eventually that will get Parkinson's disease. And these are some of the worldwide studies that have verified that. So this is something that's common and we need to stop it. So we do 6,000 visits with patients every year at University of Nebraska Medical Center, and that doesn't even count at other places in this state. So there's many, many encounters, and how do we make everyone as effective and as helpful as possible? We get Parkinson's disease by the environment. There are things in the water sometimes. There's a lot of studies on this. In our Parkinson's disease registry, we were the first state in the country with a registry for Parkinson's disease. And somewhere here I have something to drink. It's legal. Anyway, and Dr. Ming Xu, who is the director of that registry, is here with us today. And we're doing a lot of work with them, and Jill Krause has a slide we can present later. These are just some of the genes, and there are many, many genes, and there are many more other genes that interact in a complex way, and actually some of them protect us against getting Parkinson's disease. And then there's one called LRRK2, which is especially prevalent in Nebraska. And now the studies are looking at, since these are different forms of Parkinson's, specifically what do the specific, like LRRK2, people have, and how can we treat them better? Because not everyone has the same genetic disorder. Most of us don't have a genetic disorder as far as we know, and we have to individualize therapies. That's what we're doing these days. There's another one called PARK2. There's Parkin. There's alpha-synuclein, which is an important chemical that is present in, is another form of a genetic type of Parkinson's disease. But what I want to emphasize, it's not just one thing. For Huntington's chorea, there's only one way to get it. You have to have the gene, and you have to have enough of the gene product so that you actually get the disease. there's only one way. But in Parkinson's disease, there's so many ways you can get the illness. It's like a big bucket with several different subtypes in it. And there's genetic risk factors and environmental. There are some people that are like Michael J. Fox that begin at an early age, and they have tremor as a primary component. There's another type that's called akinetic rigid that happens in older people where there's not much tremor. In the younger people, the people that have tremor dominant tend to have the dyskinesias like Michael Fox. He cannot sit still when the medications are working. And I know many of you on a personal basis that have that same problem. And you can't tell just by looking at somebody unless you look again and again. The other thing I want to mention, is not in the slides, is what we're finding out is we have to think twice. Yes, you may have trouble with memory with Parkinson's. Yes, you may have trouble with your balance. But we're thinking again, and if you also have a vitamin deficiency, thiamine, vitamin B1, then you're not going to remember things very well. And we're finding now in our studies with our dietitians that there are a lot of people that are prone to getting deficiency in thiamine, vitamin B1, and in B12 and other components. We're doing an abstract we just submitted to the American Academy of Neurology. And we're actually be going to Africa soon at the end of this month to present some of our work. So the major challenge is to get a medication that is going to change things. Because exercise so far is so important that even though we don't think of it as a therapy, it's the only one that will slow the disease down. And we'll have talks about that. So when does it start? It starts at a very early age, maybe 20 years before the tremor or the slowness are evident. Constipation, loss of olfaction, other things like REM behavior disorder, those things creep up on us slowly and may not mean Parkinson's disease, but what's going on here? We know that if you have Parkinson's disease diagnosed 5 years ago, if 15 years ago you had a colonoscopy, and we look at the polyps from 15 years ago, we can prove that you were going to get Parkinson's disease by what's in the polyps. So, and Ron Pfeiffer is one of the people that has really been very early in recognizing this connection. So maybe what we eat, what's in the water, what's in the air, prevents us from smelling correctly. There may be an infectious agent, we don't really know. But at any rate, there's a lot to learn. And it eventually, there's a pointer here. I don't know if it's on this, but you can see for yourself that in the dark blue, that's where you start getting the signs of Parkinson's disease and even hallucinations. But hallucinations may also come from vitamin deficiency. So we have to be extremely careful. So this is something that just shows the same thing. The disease begins on the far left, but it's not until enough of the neurons in the brain, the cells in the brain that get affected, start to get sick and die, that we actually see the tremor and the slowness. And slowness is the key factor here. There's many subtypes, and it's not easy to diagnose Parkinson's. Okay, the environmental and the gene interplay is really kind of complicated, but there's actually some genes that will decrease the risk. There are some things that you can do or are environmental that will decrease the risk or increase it. So we need to know these things. So the patient really, we need to do the best care. So we need to have a can-do attitude. We need to get smart. You guys need to get together in your support groups. That's where the strength is. And I want to remind you that we are recording this. Todd in the back that is running this show is actually recording this so we can give it to all the support groups later on this coming year and really be up to date. Eating and sleeping well is really important. We'll talk about that. Getting stronger is important, and that's physical as well as mental, and getting educated. Don't get mad or get depressed. That's common, and we don't want to make too light of it, but get even. In other words, let's beat this disease. Let's find a way to solve it in every individual that we can, and then find a way to prevent it so that it becomes something in the history books. All right, that's what we're doing. We've also found that people with Parkinson's disease do have a higher risk for melanoma. Most cancers are less common in Parkinson's disease, so we just remember that you have to get looked at by a skin specialist occasionally just to make sure you don't have this. We did a study with 2,100 patients and found a surprising amount of people with Parkinson's that have melanoma. But this study itself probably saved 20 lives because the biopsies that were part of the study were done so early that it was a cure. So I'm not going to spend much more time. I want to get back to this as one of the causes. That's my job today. Other people will be doing more on how we treat things. But there are some disorders that are rare, that are forms of dementia that it's not even a virus, it's not even like a bacterium, it's a small particle. It's a protein that misfolds. And the top line shows the PRP, or the prion model of forms of dementia. There's a feeling among some scientists that maybe there's something very similar with Parkinson's disease. It gets in through the GI tract, it somehow gets into the bloodstream, it affects the GI tract first and gradually gets up higher and higher and eventually may cause a dementia. So this is one of the theories that is really being tested. There's a lot here, and to summarize it in 20 or 30 minutes is going to be tough. But in case you can't sleep at night, you can always look at these notes. And it's not habit forming. There is a pathology, but this is like the Supreme Court. It's the court of final appeal. People want to know, do I have Parkinson's? Well, if we could, we used to actually do biopsies, but we don't anymore. It's very low yield, and it is dangerous. So if you could donate your brain, we could tell whether you were getting Parkinson's. However, we're not good enough to put the brains back in and let you go on and enjoy your life. So we have to find other ways. So the dopamine is the chemical we're missing, and the dopamine transporter is one of the things we can look at on new imaging techniques to tell if this is getting involved at an early stage. But not everybody needs that. The disability is related to inactivity because dopamine motivates us to move and also helps us move more freely. So without dopamine, we're not going to be motivated. But you have to motivate yourselves and get moving and get into support groups, big and loud programs, whatever you can. You need to be determined. Discouragement is something that you need to talk to your physicians, your families, and friends about. And depression, like I say, you may have Parkinson's, but don't let it have you. I'm going to skip the cartoon, although that might be the highlight of this talk. I'm going to tell you that I think the hypothesis here that is most concerning to me is what if most of the disability is due to inactivity? We can do that. You know, if you don't practice reading, if you don't practice an instrument, whatever you play, you're not going to be good at it. And your mind will not be able to do it as well. I think the same is true of inactivity. Your muscles will wither. You've got to be strong. You've got to be able to, if you lose balance, you have to have quick reactions. Okay, I'll put this down below. If you lose balance a little bit, if you're strong enough, you can correct it right away. And why do you lose your balance? Well, it might be because you're developing a neuropathy from a vitamin deficiency. I mean, it's all intertwined. And there is evidence that exercise will help in this condition. And I want every one of you to leave here knowing that you can do something to strengthen yourselves. And exercise and these programs that they offer in motivating you and moving you, really important. The clinical diagnosis, I like to put it in easy ways to remember that you start with slowness. That is the Unified Brain Bank criteria in the United Kingdom that we're using still. Slowness is the key feature. If you're not slow, it's likely to be something else. You have to have a tremor, you have stiffness, and the unsteady gait. Sinemet or carbidopa-levodopa is the agent, until recently the only one that's been used to help people decide whether they are going to be helped with a deep brain stimulator. We're just doing a proposal. We started a new way of doing it, and that we're going to be hopefully presenting in Toronto next year. All right, and it's got to be the sole explanation. In other words, we've got to look for deficiencies of other things. All right, my hypothesis here is this is the brain. It's not really colored this way, but this is the way to look at it. The outer part of our brain is where we do our thinking and our planning. The inner part of our brain is where Parkinson's disease hits us. That's before we're 2 years old. We learn how to walk, we learn how to roll over in bed, we learn how to sit up, we learn how to talk, and when that doesn't work, now we have clickers to change channels on TVs. Some of you may remember we used to have to walk over and change the channel. Well, just imagine if your clicker, the inner part of your brain, isn't working. The batteries are run low, or you have Parkinson's. You push a button and you can't move your feet. You can't get out of the chair. So you have to have medications to give you help to do that. The connections we form later in life on the outside tell the inside automatic pilot to go. But if our automatic pilot is the problem, that's where Parkinson's disease is, to me, in a simplistic way of looking at it. That's why it's hard to diagnose it. That's why it's hard to manage it. I'm just going to go over these. Like I said, if you can't sleep, these will help you. But these are the strict criteria that we do our studies with, and we do our diagnoses with. So you have to have bradykinesia, slowness, and at least one of the following, and every study is a little different. But rigidity or slowness or trouble walking or tremor, remember, not everyone has the tremor. And this and the other criteria will really help us get to the answers. This is what these scans look like, these dopamine transporter scans. If you lose the cells that have dopamine in them in this illness, on the left is an essential tremor, which looks really pretty normal, like a normal person. On the right, you can see the colored areas in the middle, in the automatic pilot part of the brain, are fading away. That's a sign that we're losing those neurons and our automatic pilot isn't there for us. So this is one way of doing this, and there's a dopamine transporter scan, there's a PET scan that can be used, but this isn't necessary for everyone. We don't need this. Sometimes it helps, but usually it's not necessary. So I'm not going to go into this. Oh, you may remember, those of you here last time, 2 years ago, we got a proclamation from the governor, but that was in part because we were having an anniversary of the state of Nebraska and an anniversary of Parkinson's disease itself. So I'm just going to show it again. I've got this on my wall in my office to remind me that we've got to get on and figure this out so we don't have to get proclamations anymore. The management has got to be patient-centric. It's individualized. You're not the same as the person in the next table. You must also remember that the patient is autonomous, and it's got to be his or her idea to do whatever kind of exercise they want, but they've got to do something. The treatments here, I'll summarize by just saying, you got to have a tough attitude, and you got to get tough and physically fit. There's other things, a personal trainer. We have to make sure that your diet is good, your exercise program is good, you're getting enough sleep, all those things your mother told you to do when you were a kid. And research is very important. We need to have people like you volunteer, and I know many of you have, and you have benefited, and we've all benefited from your cooperation in these studies. So we have to focus on the motor complications that we can manage, but we can also get closer to the answer. So how can we get even better? Our resolutions are the best quality of life and quality care. So we, according to the Academy of Neurology, we must do these things. We have to rethink this every year, rule out treatable causes. We've got our own 10 commandments that we've added to that. So I hope, and we are talking about the registry today, please go up to the table, try to learn everything you can, support the registry. There are people that want us to not have a registry or not to make it easy to get the information from it. So, and we're going right to the map of Nebraska. I think I'm going to end on this note. Joe Kraus is the person that you can contact. Dr. Mingshu is the director of it. I really want you to have a chance to ask your questions. There'll be a lot of opportunities today. And